Hello and welcome to this month's Masterclass, which is all about hair loss in women. So this is a very big topic, so I'm going to break it down into a few chunks just to make it accessible and something we can talk about in a 10-minute masterclass. So hair loss in women, really big deal, something I see in my clinic pretty much every day. So the first thing to talk about when dealing with hair loss in women is that you have to get the diagnosis right the first time, preferably. So the way we look at hair loss is by separating it into two categories. So you have scarring hair loss and non-scarring hair loss. Thankfully, I mainly see non-scarring hair loss. And what that means is that the hair loss I'm seeing in my clinic, or that people are coming to my clinic with, is the type that can get better. It can recover. So a scar is a permanent hair loss. So if you have scarring hair loss, that means you have patches of hair loss and the skin overlying it is basically scarred and the hair loss won't come back. So the hair follicle has been destroyed. So different types of scarring hair loss include things like lichen planopilaris, frontal fibrosing alopecia, folliculitis decalvans, dissecting cellulitis. These are thankfully relatively rare and something I don't even see in clinic that often. But when I do see it, it's quite devastating for the patient. So getting the diagnosis right is the first thing. Now that involves taking a thorough history from the patient, listening to the patient's story, asking the right questions, and of course, examining the scalp. So with scarring alopecias, you generally don't see a hair follicle, but with non-scarring, you still see hair follicles as little dots on the scalp when you look at the hair. So also, the pattern of hair loss is different. So in scarring alopecias, you would see potentially hair loss from the frontal hairline, which is not common in non-scarring alopecias. You also see redness around the hair follicles. You can see scaling and inflammation around the hair follicles. So those are all signs of scarring alopecia. In my opinion, scalp biopsies are really very rarely necessary or helpful. Most hair loss can be diagnosed clinically, so by examining the patient and taking a data history. So once you've established that, then you can go on to treatment. What I'm going to talk about now is the three most common types of hair loss that I see in my clinic. And those are alopecia areata, which is an autoimmune hair loss, androgenetic alopecia, which is female pattern hair loss, and telogen effluvium, which is kind of acute onset stress-related hair loss. So let's just go through those one by one. So the first one is alopecia areata. I was like, which one was I talking about first? So alopecia areata, like I said, is an autoimmune related hair loss. So that means that for some reason, your body has decided to attack hair follicles in certain parts of your scalp and kind of stop that hair follicle from working, and you lose the hair in that patch. It generally occurs in patches. So you get like a coin-shaped patch of hair loss here, wherever, and it's completely gone. So there's no hair in that area at all. And often when it regrows as gray hair or with a different texture. Like it can be like more coarse or curly than your normal hair, but usually eventually it goes back to normal. You can also have alopecia areata that affects your whole head. It can also affect your eyebrows or your eyelashes. So when I have someone who comes in with sudden onset hair loss that's coin-shaped or perhaps even affecting the whole head, then I need to decide what type of hair loss I'm dealing with. If it's alopecia areata, then we have to dampen down the immune system in order to get the hair to grow back, kind of shut off that immune process. The best way to do that is with injecting steroids into the scalp. So generally speaking, you inject steroids, what's called intralesional steroids, into the patches, and that stimulates the hair to grow back. You may require more than one round of injections every couple weeks to really get the hair to grow back. I often also prescribe topical steroids in scalp applications to be used at the same time to also try to stimulate the hair growth. If I have a patient who has all their hair gone, then often they need something like oral steroids, prednisolone, in order to stimulate the hair to grow again, because you could inject the whole scalp, but it can be quite painful. So in that situation, I would use an immunosuppressant like prednisolone in a short course to stimulate the hair growth. I sometimes do everything at once because patients become so distressed by this, and it can really affect your quality of life. So we really need to get the hair to grow back ASAP. Generally speaking, I've had great results with all those treatments, and my patients have had their hair grow back. So, and I've had patients with hair loss like all around the lower head here, lots of patches in the scalp, or even just one really big patch here, which can be really difficult to cover if you're trying to cover it with your hair. So these all respond to immunosuppression. Usually your first protocol would be intralesional steroids, so injecting steroids into the scalp. After that, perhaps you would look at a course of oral steroids and just working closely with your doctor to report back hair growth. Often when the hair grows back, initially the patient doesn't see it because obviously it's hard to look at your own head, but also the hair growth can grow back as white. It can be very fine, like vellus hair, so then you have trouble seeing it yourself. But I look through my dermatoscope and I can often see very fine hair regrowth to reassure the patient the hair is growing back. So the next one, and this is probably the most common one, is androgenetic alopecia, or female pattern hair loss. Now this is very devastating for women. It tends to present in postmenopausal time, like around 50 and after. But I also see it occurring in younger patients starting around 30, 35 years old. And predominantly what you have is you get a widening of your part. So if you have a parting up here, you find that you can see more scalp. And that's usually what patients say to me. They're like, I can see my scalp more. And it's been very gradual and slowly coming on like that over the past few years. And now I can see my scalp. Usually in female pattern hair loss, or just basically generally in it, the frontal hairline is preserved. So unlike in men, where you kind of get bald, men get bald from their frontal hairline, they lose all their hair here. Women with androgenetic or hormone-related hair loss or age-related hair loss, they don't get that. So you get widening of the parting here. You sometimes get a bit of temporal hair loss, but it can also be diffuse hair thinning. But the frontal hairline is maintained. Very rarely do women go totally bald. I have yet to see a woman go totally bald from female pattern hair loss, and that's usually the main concern. Just to look at some stats, the incidence is 29 to 38% in women over the age of 70, and only 3% in women aged 20 to 29 years old. So it's much more common in the postmenopausal period. And why it happens. So this is why we think it happens, or how it happens. You have androgen responsive hair follicles. So androgen is the male hormone, but that women have it as well. And your balance of your hormones gets skewed as you get older and when you're kind of going into menopause. So your androgens perhaps become more dominant, or you become more sensitive to androgens while your estrogens decline a bit. So what happens in female pattern hair loss is the androgen responsive hair follicles gradually shorten their growth phase, which is known as anagen. And then it results in more follicles going to the shedding phase, which is known as telogen. So you get more hair shedding and less hair growing, and then you end up having this conversion of your hair from terminal follicles, which is the thick hair, to vellus, which are the fine, thin hair follicles, and then you see that your hair is thinning. So that's generally what happens. What happens is that you have circulating free testosterone, which comes from your ovaries and your adrenal glands. It enters cells, it converts to something called dihydrotestosterone, DHT, and then that DHT hormone acts on the androgen receptors in hair follicles to stimulate this shortening of anagen and lengthening of telogen. Now, in most women, there is no increase in androgen levels. So if we did a blood test, we wouldn't see any hormone changes, except if you have something like polycystic ovarian syndrome, where you would have, raised androgens potentially. Estrogens also play a role because they stimulate hair growth. So that's why we see this often in postmenopausal women. Now, in terms of treatment, because I know that's what you're thinking, minoxidil is the only treatment that's been approved by the US FDA or the MHRA for the treatment of female pattern hair loss. We don't know how it works, but it seems to increase the growth rate of hair. It causes a thicker diameter of the hair follicle, and it lengthens that anagen phase, that growth phase, which is shortened in female pattern hair loss. Now, 2% is the licensed percentage for women and 5% for men, but in big trials, the 5% has always shown superiority over the 2%. So I generally recommend my patients to use 5%. That's what I prescribe myself. And the only side effects are kind of local irritation to the scalp, itching, a bit of redness, annoyance. And the 5% is worse or causes more irritation than the 2%. So the 5% causes more local side effects than the 2%. Now, that's the only one that's licensed, but people always ask me about other treatments. So there's been one large placebo-controlled trial looking at something called oral finasteride, which is a 5-alpha reductase inhibitor, which stops the conversion of testosterone to dihydrotestosterone, and is licensed for the treatment of male pattern hair loss in men. Now, in this placebo-controlled trial, they gave 1 milligram of finasteride to postmenopausal women for 12 months, and they gave another group placebo, so just a dummy pill, and there was no difference. So it didn't look like finasteride did anything to affect hair loss or hair growth. The only tablet drug that really could do it is spironolactone, which is a blood pressure drug that's also an anti-androgen, and it's been shown to increase hair growth when taken up to 200 milligrams per day, and it can work quite well, and it blocks the androgen working at the receptor, so that can be quite helpful. So female pattern hair loss, just to sum it up, it's actually really quite common. I would say that probably 50% of women over 40 have some element of female pattern hair loss, and the only really strongly evidence-based treatment is topical minoxidil, though I would suggest using 5% over 2%, and just be aware it can cause a bit of irritation. It also takes quite a long time to work. I've done a masterclass all about minoxidil, which is available here in the YouTube channel, so have a look at that. So the last one we're going to talk about is telogen effluvium, and that's acute onset stress-related hair loss. I've been seeing more telogen effluvium recently, and I think it's due to COVID. A lot of women are telling me they're getting hair loss after they had COVID. It tends to occur 3 months after the triggering event. So like childbirth, it can happen 3 months after childbirth. A stressful event is like a death in the family, any kind of stress-related life event. Moving house can do it, moving countries, new job, anything that's really stressful. Moving is a life event. And it usually resolves 3 to 6 months after spontaneously, so it just resolves. Now, normally, in normal hair growth, only about 10% of your hair is in the telogen or resting phase, and or the shedding phase, and most of your hair is in anagen, so it's growing. But in telogen effluvium, that ratio shifts. So you have about 30% in the telogen or shedding phase. So you have this kind of increased proportion of hairs in the shedding phase. So you find that you're just having an increased number of hair fall every day. Usually people lose about 100 hairs a day, but in telogen effluvium that can increase quite markedly, and suddenly you're seeing loads of hair on the floor when you wash your hair in the bathroom floor and so on. And that's telogen effluvium. So there's nothing much you can do for this besides perhaps use minoxidil. And I've given minoxidil to my patients who have like post-COVID telogen effluvium, and it seems to work very well for them. But really, time is the best thing for telogen effluvium because your hair will settle down and grow back again. It does not cause complete baldness. Your hair will grow back, but it can be very difficult to be patient and wait because it is so scary to see all your hair coming out every day. And you just think, oh my God, my ponytail is half the size it used to be. What's happening? Is this going to stop? And I can reassure you that yes, it will stop, but there's not a ton I can do to help you. So to sum up, that is the masterclass in hair loss for women. The main points are get your diagnosis right, hopefully the first time. There's a difference between scarring and non-scarring hair loss. The most common, luckily, are non-scarring. So your hair will grow back usually with potentially help from some minoxidil. The 3 most common are alopecia areata, which is immune-related hair loss. And then there's androgenetic alopecia, which is female-related or age-related hair loss. And then telogen effluvium, which is stress-related. I hope that was helpful. Obviously, let me know if you have any questions, and the notes are below. Till next time.